Well, the Thames Valley has a lot of good things to offer for emergency medicine training. It's got a really trainee-driven programme at registrar level. We have a very good interactive website. We have weekly training sessions where the trainees meet up around the region. And we also have now a yearly conference organised by the trainees, but that now is getting a lot of national interest as well. And then the other big thing, which is we're noticing our specialties, obviously sub-specialising is becoming much more popular. And in the next couple of years, we're hoping to be accredited for pre-hospital training and hopefully over the next few years as well for paediatric subspecialty training. We also have a number of links with the University of Oxford, both with research and education, which are things that you can pursue if there are interests in particular. Obviously we've got Oxford, which is the major trauma centre, and then around that we have our DGHs, but the DGHs themselves are also very big. They all have the advantage they're very well staffed by consultants, so you have a lot of sort of senior cover and senior input both in your training and support in your actual job as well. In the major trauma centre, I've already mentioned that we're going to be getting pre-hospital training accredited. So that means as a trainee, you'll be able to go out on the vehicle to the accident. You may even be able to go out on the helicopters itself when you've had training in that. But it also means that in the major trauma centre, we receive all of the large trauma from anything that comes from around 45 minutes around. So it's a very unique training opportunity to Oxford. And as well as the trauma, Oxford is just very busy, so we have a lot of other medical cases that we see. It's a challenging time for emergency medicine at the minute. So if we look at what's happening over the, what's likely to happen over the next 10 years, I think consultant expansion is something that needs to happen and currently is happening. So I think eventually there will be 24-hour consultant shop floor service so that we have a senior decision-making led service. I think we're looking at the expansion of subspecialty training. That's really well recognised, and the ones that exist at the minute, paediatrics and intensive care, pre-hospital is now recognised as a subspecialty training, and academic emergency medicine is a new branch as well that is emerging. I think in terms of as well as clinicians, I think emergency medicine has often been seen as a sort of triage-led sort of specialty where we're just responsible for triaging people, and that would be one of the main criticisms we're faced. I think one of the things in our specialty that's really exciting is because of our subspecialty training, we're getting more practical and hands-on skill, and we're being able to do things that were traditionally not considered the job of the emergency physician, whether that's from airway, from using our ultrasound skills, from being more involved with paediatrics from the beginning as well. When we're recruiting to emergency medicine, we're looking for a number of sort of personal qualities. I would want to see someone who's enthusiastic and sort of really driven by the specialty. And that might be shown from a commitment to the specialty early on. So for example, they may have done an elective in emergency medicine, they may have done a taster sort of in emergency medicine and done some of the sort of allied courses like ALS or ATLS. But I think the other sort of personal skills that are needed, you know, the emergency department, it's a busy, stressful, intense department. So we need someone who thrives on a challenge, likes working in that sort of intense, stressful environment, but also that works really well within a multidisciplinary team. The emergency department doesn't have the hierarchical structure that still exists in many aspects of the hospital, and that's fantastic. So you're working with everyone from the portering staff to the nursing staff on a sort of first name basis, and that's really sort of unique to the emergency department. I think we also look for people who are great at communicating. You've got to be able to make decisions quickly, and you've got to be able to work as a sort of a team leader as well. But those are all sort of skills as well that you would pick up through your training. I think the other thing that's really, really useful when you're thinking of applying to emergency medicine is to get a mentor in the specialty. That can be maybe a consultant, it might be a registrar, but someone who you feel is maybe looking for has got a similar work-life balance to what you will ultimately want to achieve. So for example, I always knew that I wanted to do emergency medicine. I did my elective, I loved it, there was never any other specialty I wanted to do. But when I was in Warrington, I was doing a trauma job there, I went down to the emergency department because I was missing have been working there, and I met one of the female consultants there who sort of represented what I felt I would like to be, and she really mentored me through that 6 months. So even though I was doing a trauma job, I spent 6 months going down to see her. She gave me advice what I could do, how I could improve my CV so that when I did apply for my registrar training, you know, I could have the best CV that I could have. And I think finding someone like that is really useful for your sort of training. I think anyone who's worked in an emergency department will see that there's a lot of number of specialty doctors that work in the department. I think the specialty doctors at middle grade level really form the core of the emergency department from the point of view of staffing and helping to run the department. But I think it isn't just about service, and I think the department does offer a lot of opportunities for middle grade doctors. A lot of the ones that I'm currently working with want to actually either go into training, so they have the same teaching opportunities, the same mentoring, the same educational supervision as you would have as a trainer. And then the other thing to use it as, if you can't commit to going at this point going into a run-through training because you want to travel or you want to do some other things while you're young, the great thing is you can do a 4-month middle grade job and then improve your finances and then use it to go off travelling or to do something else in medicine. We had a girl who just worked for us for 5 months and is now doing work in Botswana before she returns and does a training number and completes her registrar training in emergency medicine. As a specialty doctor, if you then decide that you want to actually become a sort of a career training doctor, we actively encourage that, and we would try and help. One of the reasons we sometimes struggle to recruit to emergency medicine, and I think one of the reasons why people often drop out of the specialty, is because it is seen as this very intense, very stressful place to work where you'll often work antisocial hours, and therefore that it doesn't fit in with having a life outside of medicine. And certainly on the surface, as a junior doctor, when you compare what you'll do in the emergency department, for example, to a psychiatric attachment, to a GP attachment, it might look that way. And I think that's probably one of the number of reasons why people, although they do their attachment and they say they love working in A&E, they don't want to consider it as a specialty, or later on they drop out. But to those people who actually really love it and still want to do it, but are concerned about the work-life balance, I would say talk to the consultants who are actually at the end, because I think what you'll find is that actually when you get to the end, sometimes the work-life balance is a lot better than you think. My typical working week as a full-time ED consultant is a 3-day working week, and I work a 1 in 4 weekend commitment with that. And when I compare that with my friends in general practice, for them they would have to work a 5-day working week for a full-time GP equivalent. Whereas I'm coming in, I'm doing my 9-hour, 10-hour shift, do my shift, do my hours, clock off, go home. And it's very sessional based, which makes it very attractive for sort of part-time or flexible working. When patients come to present to the emergency department, it's sometimes the first time they will have ever been to a hospital. And so we personally have that responsibility and that opportunity to make that visit to hospital as pleasant an experience for them as it can possibly be. And that will often, especially as a child, imprint on how they view the health service, they view health, and they view hospitals potentially sort of for the rest of their life. And I think from a clinician's point of view as well, it's incredibly challenging because we're labelling that patient with that first diagnosis that will then often carry with them for the rest of their hospital visit. So that's an incredibly important and responsible thing that we have to do.